Yeah, sure, we should start because we have a bit of a long case today. So, for the chief complaint, we have a 36-year-old female who presented with headache and joint pain at the emergency.
Okay, this is interesting, and Joseph said this is going to be it's going to be an amazing case today. So I'm looking forward to learning a lot. So a 36 years old female presenting with headache and joint pain, and you say that the emergency department. So we are not given we are not given the duration of these symptoms, and therefore, whenever I discuss a case, what I try to see, and because this is a case that has already been processed to some extent, so I look for a number of points which can help me make progress, and one of them is time, cause we are talking about headache and joint pain. Both of these complaints we have discussed here a number of times, and these can be both acute and chronic. So if you are talking of an acute presentation of headache and joint pain, a constellation of these symptoms together, there is a number of differentials that I'll think about. Acute ones, so just to mention a few, malaria can present this way, although we maybe in that case would expect another complaint of something like fever, but then you also have viral infections like dengue and others. So I think time course is also very important, because here we have something about epidemiology, just a part of the story. This is a 36 years old female, and then we have symptoms which have not yet added to a syndrome. So we'll derive that from the HPI in order to pick a clear-cut syndrome which can help us narrow down the differentials. So one thing that we are missing is the time course. Although, because this patient presented at the emergency department, it can be easy to make an assumption that these are probably acute symptoms. That can be corrected to a large extent, because assumptions save us many times. But then it could also be wrong, because maybe this patient has been having these symptoms for a long time, but they have been on and off, and therefore maybe this is a presentation where the symptoms have become unbearable, and that's why she decided to come to the emergency department. So I think at this point I'll just sit back and listen to the HPA, and then I'll see what I can get out of it. Back to you, Joseph.
Yeah, duration is everything. So let's see the HPI. Starting with headache. She said 9 months ago she experienced a left-sided jaw and head pain. She presented to another facility where it was thought that the pain came from the toothache, and she underwent dental extraction at that facility on the same day. But she noticed there was no improvement of the pain following extraction. 3 days later, her husband noticed she was speaking like a very drunk person, which was progressive over time to the point it was hard to understand when she spoke over a few days. And a few weeks later, husband noticed she developed memory loss. Later on, she developed insomnia, but there was no history of loss of consciousness, convulsions, visual disturbances, hearing loss, psychotic features, mouth deviation, limb weakness, urine or fecal incontinence or retention, numbness, paresthesia, fever, rash. Going to joint pain, so this preceded the headache. She said that in 2018, following a delivery of her first child, she developed pain in the hands and wrists. It was associated with swelling of the involved joints and morning stiffness. Pain limited the activities. She was attended at an orthopedic hospital with an OT surgeon who told her she had rheumatoid arthritis. She said they sent some lab, but she didn't know which lab came positive at that point. and then she was given meds which helped with the pain. From that moment, from 2018, she would develop episode with intense pain, swelling, and stiffness of the joint, which she would manage with NSAIDs. But other times, she would stay pain free without any meds. So she denies neck, back, or hip pain. She denies painful urination, PV discharge, genital ulcers, painful coitus, or history of husband being treated for STIs. She denies eye pain, diarrhea, or rash. That's a long HPI.
Okay, very interesting. And so, just like I said earlier, we needed the time cause, and uh, I see that what I was my worries came out to be true. That probably you are not just dealing with something acute, but it's something chronic, and then maybe uh, there is something that has triggered them to come to the hospital at this point. So 9 months ago, so this is so we are stepping into the chronic territory. The patient experienced left-sided jaw and head pain. So what I'm doing, what I'm trying to do, many times when I hear when we hear symptoms, what we try to do. Let me let me mute someone here. So many times when we hear symptoms, when someone comes with a certain presentation, initially, although when you are taking history, basically what you are trying to do is to recognize a certain pattern. And there are some buzzwords that when we hear sometimes, they make us think of some things because they have been tied to certain diagnosis to an extent that it becomes they are considered as pathognomonic features of those illnesses. So, for example, when we hear of jaw pain, and so this patient is presenting with left-sided jaw as well as head pain, I think of a number of things, and then what holds me back is the epidemiology once more, because when you talk about headache and maybe jaw pain, which of course we would expect a little bit of qualification, which is intermittent claudication of the jaw claudication, especially with chewing. You think of things like giant cell arteritis, but then giant cell arteritis, as I said, the epidemiology is holding me back because it's mentioned many times as almost exclusively a disease of people above the age of 50, and therefore are also lacking the qualification about this jaw pain, and of course the age itself uh, makes me have some reservations on this diagnosis. But then we are dealing with the headache. Let's say it's a headache, and then there's also jaw pain. So a tooth extraction is done, there is no improvement. And then the patient was speaking like a very drunk person. So I think one duty that I have here is to try and make an interpretation. If someone comes to you, because they describe things in their own words, she's speaking like a very drunk person. So what are we talking about? What are we talking about? Probably one of the things is she's presenting with a slurred speech. So that is an assumption that I'll make here. And as you've seen in other cases, the way you interpret certain clues, so some clues that are presented in history, or in any part of your patient encounter, or whenever you are solving any case, there's a piece of information that will be presented. That piece of information will either be signal or will be noise. So it's up to you to decide whether this is noise and this is signal, depending on the patterns that you're recognizing, depending on your knowledge base. And of course, slow thinking sometimes is very important when fast thinking doesn't seem to lead you where you are going. So I'm making an assumption that it's probably slurred speech. And I think this is a very critical assumption because it can either lead me to a diagnosis or mislead me completely. Can I see the next slide? Okay, so a few weeks later, the patient presents with memory loss. So I'm trying to see here memory loss and then something that sounded like slurred speech. And then she later on presents with insomnia. So that keeps me thinking, whatever we are talking about here probably involves the neurological system in general, especially when you hear about memory loss. You are talking about the cortex and some other associated structures. And then we also talked about slurred speech. So there's a number of territories here, probably because, of course, when you talk of speech, I mean, it can be anything from all the way to the cerebral cortex, as we talked about. And it can also be because when you talk of speech, it can also be involvement of some cranial nerves which are involved in you can have dysarthria, which is cerebellar in nature, and you can have from paralysis of some cranial nerves which are involved in speech production. But then if there is memory loss, that makes us think about something in the higher centers. So memory loss, insomnia, and then what I interpret to be slurred speech. But there is no loss of consciousness, no convulsions, no visual disturbances, and then no hearing loss, psychotic features, mouth deviation, limb weakness. We do not see any motor symptoms here, at least peripherally, and then no features of incontinence, no numbness, paresthesias, fever or rash. Can I see the next one? Okay, so joint pain. Now, this joint pain, again, another chronic complaint, and that was following delivery. It involves hands as well as wrists. And then it's associated with swelling of the involved joints as well as morning stiffness. So I think we've discussed the joint pain many times here. And we've talked about how sometimes you judge this pain as being something inflammatory. So we are talking of joint pain. Joint pain can be an arthralgia or it can be arthritis. So what I see here is pointing me in the direction of arthritis. The swelling, the pain is associated with morning stiffness, and there is a limitation in activities. Of course, this can happen with many kinds of joint pain, even if it's not inflammatory. And then she was told she has a rheumatoid arthritis. Now, I think there is a number of pieces of information that are missing for me here. Counting the number of joints in order to term this as an oligoarthritis or a polyarthritis, I think that is the main one, and another one is an issue of symmetry, because those are, at least for me, important things when I try to consider certain differentials. Okay, next slide. Okay, so these are episodes of joint pain, it seems they have been intermittent with swelling, stiffness. NSAID seem to be helping sometimes. However, no neck or back or hip pain, no painful urination, PV discharge, genital ulcers, painful coitus or history in the husband being treated for an STI, no eye pain, diarrhea, or rash. I think these are important symptoms to rule out, especially with the joint pain. So, some quick thoughts that I have: the joint pain that we are talking of is an inflammatory arthritis. Whether it's an oligoarthritis or polyarthritis, I look forward to more details. And whether it's symmetric or asymmetric, I hope Joseph will help me with that. But I already see some signals here that we are dealing with inflammatory joint pain and inflammatory kind of arthritis. And therefore, a number of things are worth considering. Infections, those numbers of joints that are involved, the infections are less likely, but you can all remember we discussed the case of a disseminated gonococcal infection here, and I think it can explain part of the patient's presentation. Another thing is advanced syphilis. So if you talk of secondary or tertiary syphilis, it can have some neurological presentation as well as joint presentation, and therefore among infections, I think I need to entertain those, although the last bullet there is against it, but we cannot completely rely on that information because it can be a distant history and someone could not pick those antecedent symptoms. So I think among infections, syphilis as well as a disseminated gonococcal infection are important to consider. And then autoimmune disease, I'm trying to tie both symptoms here. We are dealing with headache, jaw pain, some neurological symptoms, including memory loss, insomnia, as well as what are interpreted to be slurred speech. So, is there any autoimmune condition that can tie these together? So, I mentioned giant cell arteritis. Of course, giant cell arteritis is associated with polymyalgia rheumatica. So that can explain the patient's presentation. But as I said earlier, epidemiology is against it. Epidemiology is against that. As I said, giant cell arteritis is more common in people older than 50. So your typical patient will be a male who is older than 50 years. Although giant cell arteritis, I cannot remember the sex predilection, but it's more common in that age group. Therefore, I think presentation is in keeping with that, but a part of it, at least the headache and the jaw pain, but then age is against it. Rheumatoid arthritis, I already mentioned my reservations. I do not have information on the symmetry and number of joints involved, but I think autoimmune diseases like rheumatoid arthritis, SLE, because SLE can also present with some neurological symptoms, although many times actually you talk of psychosis. But I think an autoimmune condition is also worth considering. Another thing is a malignancy. Something that is against a malignancy is that the presentation seems to be on and off, and so it's more of intermittent. We would have expected progression. Yes, malignancies, I can not maybe mention specifics at this point, but as a paraneoplastic syndrome, it can explain joint symptoms as well as a neurological presentation. So I think I still have a long way to go, but those are my thoughts for the moment. So back to you, Joseph.
Yeah, thank you. It was like symmetrical, many joints of both hands and the wrists, so polyarthritis. Yeah, reviewable system. She had weight loss from 70s to 60s kgs. There was no history of abortions or complication during pregnancies. Past medical history, nothing significant. Family and social history. She was married, she had two kids, her first relatives were in good health. She was a homemaker. She didn't smoke and didn't drink, and she didn't use other substances. And to remind
Okay,
you,
so
so I said it's a bit of a long case, and we just spent like half an hour now. Maybe we keep that in mind.
yeah, I'll try and be fast. I think in the next part. So I think something to be added here is uh, we are dealing with an inflammatory polyarthritis. I think I've already discussed some differentials, and then an extra piece of information: significant and intentional weight loss, I believe. So again, when we talk of weight loss, we've discussed a number of times here. You have to consider a number of things. Is it an intake problem that this patient is having a reduced oral intake? Nothing has been mentioned of that here. Is it a digestion or absorption problem? We would expect diarrheas if this patient was having malabsorption. And then maybe the patient is having absorption and intake are fine, but then there is an increased so the patient is in a catabolic state. You have an increase in basal metabolic rate. So things like tuberculosis among infections are important to consider, but then we have not had anything else. So no fevers, night sweats. HIV, I think, is an important thing to be considered, although it's a long history. And if we are talking, maybe the patient was seen this year, since 2018, I believe many other things would have come up. But then I think it's important to also screen this patient for HIV. So that's among infections. And then something like diabetes explaining the weight loss. Diabetes explaining weight loss, but then the joint symptoms, we would expect pathognomonic symptoms like polyuria, polydipsia. Weight loss is already there. So I think screening for diabetes is also important in this patient, but it doesn't explain everything about the patient. So another thing is malignancies. I think I already mentioned that it's important to consider, but then the patient's presentation doesn't seem to be very progressive to explain a malignancy, although I think it's too early to throw it away completely. So I think those are additional pieces of thought. Of course, with the neurological presentation, that's something that I also wanted to mention. I think it's important to consider drugs, but we are being told the past medical history is unremarkable. This patient is not using any substances. So let's proceed to the physical examination and see if we can make more progress.
Okay, nice. General exam. She was alert and oriented times four. She was febrile. She was not pale. She didn't have jaundice. There was no peripheral lymphadenopathy and low lower edema. Her vital signs were within normal limit. Of importance of the neuro exam. So, higher center exam, she was alert and oriented times four. She was normal. She had an impaired short term memory. You tell her, I'm telling you this, and you'll tell me later what I told you, but she forget that thing. She had dysarthria, and also she had receptive aphasia. Her cranial nerve exam was normal. Motor, she didn't have wasting, fasciculation, or involuntary movements of the muscles. Power was normal in all four limbs. She had a normal tone. She didn't have a pronator drift. What I saw from the both limbs when I did my patella hammer was hyperreflexia because they are both limbs. I didn't know if that was the baseline uh, or it was maybe a new thing. So, but I'm reporting here what I saw. It was pretty hyperreflexia of both patella, but the frontal effects was mute, and she didn't have a clonus, and the coordination was normal. She had an intact sensations. Chest, clear transcatation by artery, abdomen, non-distended and tender, no organomegaly. And cardiovascular, she had a regulating rhythm with no mama.
Okay, so I think neuro exam will help us. Let me see the slide on neuro exam, because general examination seems to be unremarkable. Yeah, so impaired short-term memory, and then receptive aphasia, and then you also have dysarthria there. However, cranial nerve examination, normal. So as I talked about slurred speech, turns out it's true. This patient was having slurred speech, and the kind of dysarthria now that we are talking about, I said we have cerebellar dysarthria. So I see that because coordination and other things turned out to be normal, maybe the kind of dysarthria that we are talking about here is not cerebellar dysarthria. Although, again, I believe, I think neuro is more complex than this. We cannot segment things in boxes all the time, but I'm making quick assumptions here that the kind of dysarthria that we are talking about is probably not cerebellar. And since the cranial nerves are normal, so most likely, again, we are not talking about something like a bulbar palsy. So receptive aphasia, the dysarthria that we see here, and then impaired short-term memory. So the area, when you talk of short-term memory, I will not try and localize to the nitty-gritty details, but it's the hippocampus is involved in registration as well as short-term memory. So basically, or more broadly speaking, it's around the temporal area. So when I see receptive aphasia, I think one of the areas that I quickly think about is, okay, we are having an issue in the temporal area, probably. Cranial nerves are normal, and then motor examination, hyperreflexia. So isolated hyperreflexia, normal tone. This is interesting. And then you have coordination is normal, sensation is intact. Other parts of examination are normal. So, well, a number of things come to mind with this kind of physical examination. And yeah, this is a tough case. A number of things are coming to mind. So I think especially some kinds of dementias. Although this patient is having no problem, we do not see any, and I believe that is the case, Joseph, that this patient, apart from the slurred speech that we've been told about and the insomnia, I do not remember there was nothing behavioral. And then there were no bladder symptoms. So there are some kinds of dementias that can partly explain this kind of presentation. Although when I talk of dementia, I think that will be more loosely used, because we expected some of those components I've mentioned, like behavioral changes in addition to memory issues. But with the limitations that I have at this point, I think I should just say I have not been able to localize completely where the pathology is. But I think I'm considering the temporal area because of impaired short-term memory, because of receptive aphasia. I've not seen a specific place to tie the dysarthria to, and the hyperreflexia that is seen isolated hyperreflexia with normal motor and sensory examination, normal tone. So I think that's where I am. Let's see the investigations and see if I can make progress, and maybe later on I will come to these pieces of information and see what I can get.
Sure. Here are the labs. White count was normal. Normocytic, mild anemia of 9.5. Hematocrit 30, reduced. Platelet was normal. ESR raised at 70. Renal functions were normal. Liver enzymes were normal except for GGT, which was 75. Thyroid functions were normal. Hepatitis B surface antigen was negative, but hepatitis C antibody was positive. HIV was negative. So these are the labs that, like, this patient came from other two hospitals. She had labs. My also the third one. So the labs we're seeing, they look the same except for rheumatoid factor. It was negative in two hospitals and then positive in one of the hospitals. So I sent this anti-CCP, came back negative at less than 7. Uric acid was normal. Average was 4. In one of the hospitals, she did Siramada, which was elevated at 18, and urine analysis had leukocyte plus 1. Yeah.
Okay, so okay, I'll discuss this quickly. So we see a mild anemia and then an elevation in ESR. Of course, I think we had that assumption since long ago that there is some sort of inflammation in this patient, and then isolated elevation in GGT. I do not know what to make out of this, because other liver enzymes are all normal, as well as as well as liver function test, including bilirubin, which seems to be normal, and then thyroid is normal. So hepatitis C antibody is positive. So there are what we can call extrahepatic manifestations of hepatitis C. So these hepatotropic viruses can present with many symptoms, or can have many presentations outside the liver. So one of them being in joints. So hepatitis viruses, especially both B and C. Actually, I think I should say C. I think it has a more protean extrahepatic manifestation, maybe, as compared to hepatitis B. So the joints are one of those areas. The kidney is another. I think most of us know that. And then you also have cryoglobulinemias, which can present with hepatitis, and it also has neurological manifestations. Now, to be specific, what neurological manifestations, I think I would need to go back and read about that. So does hepatitis C explain everything in this patient? I'm not exactly sure, but I think that is that's an observation. I think that is one piece of information worth considering. Is there anything else? So rheumatoid factor positive, uh, sensitive, but not very specific. I think another thing that I need for this patient is a VDRL, also important, because rheumatoid factor and VDRL, these things can you can have a positive rheumatoid factor in a patient who has syphilis, advanced syphilis, like I mentioned. So I think some treponemal tests are also important to check in this patient. Yeah. So another is there anything else apart from the fact that this patient is having a mild anemia and then an elevation in ESR, and then hepatitis C positive, an elevation in GGT, which I do not have answers to, and then seroconversion in rheumatoid factor. So maybe I should try and represent the problem at this point. A 35 years old female with an unremarkable past medical history, presenting with a number of years of symmetrical polyarthritis involving small joints of the hands as well as wrists. And then she also presented with a headache and jaw pain about 9 months ago. Later on, presented with symptoms of insomnia, slurred speech, as well as memory loss. On examination, the patient has short-term memory loss, has dysarthria, as well as this other thing was receptive aphasia, and then hyperreflexia on knee hyperreflexia. Other systemic examination normal, and then we come to labs. We see a mild anemia, inflammation with elevation in ESR, and then an elevation in GGT, hepatitis C, virus antibody positive, and then rheumatoid factor positive. Yeah, so let's see other pieces of information and see if I can make any progress, and I'll keep visiting my thoughts to see what I can make out of this.
Yeah, thank you very much. So yes, VDRI was not here, but it was done and it was negative. But I would love you to teach the audience one thing, because I believe you know this better than me. Should we take this hepatitis C antibody positive as the diagnostic for this patient, or what do you think?
Yeah, so what we do is because this is a rapid test, so what you need is you'll need to do a, should I say, not genetic, but a molecular, or yes, a molecular test. So you do PCR, whether qualitative or quantitative. Quantitative will give you the titers, but qualitative, if so you order, is that a reverse, is yes, it's PCR, but then is it reverse transcriptase PCR, or is it just PCR? If you order those molecular tests, and they all nucleic acid amplification tests, and they come out positive, whether qualitative or quantitative, then you know that you have an active infection.
Oh, yeah, that's very good. Yeah, so let's proceed. And yeah, because I asked that because this patient doesn't have any risk factor for hepatitis C. Yeah. So we sent ANA, came back 261. Machines limit is 16, the upper limit. Does this change anything?
Well, so a positive ANA, I think in light of the patient's presentation, asymmetrical polyarthritis, and the other presentation that we see, a positive ANA, I think is an important clue of information, because we already have suspicion an autoimmune disease is among things that we are considering. And therefore, a positive ANA, I think, cannot be taken as noise in this patient, because yes, ANA can be noise, but this is a high titer. This is a high titer, and therefore, because I've said a number of times here that you can have ANA positive in up to 5% of the general population who do not have an autoimmune disease, and that percentage keeps on increasing as age increases. But then this patient is having a syndrome that is consistent with an autoimmune disease. At least it's one of the differentials that we are considering. And then it turns out this much high. I think it's important. It's an important clue of information.
Oh, okay. So yeah, ECG and echo were unremarkable. So she came with the brain CT, which showed multifocal areas of hypodensity mixed with hyperdensity on the left frontal parietal temporal region involving the middle cerebral artery with no mass effect. The radiologist's differential diagnosis was hemorrhagic transformation of an ischemic infarct, and he said kindly correlate clinically. She also came with a brain MRI, which shows small foci of restriction diffusion scattered in the left temporal parietal occipital region, left MCA vascular territory, predominantly within the left parietal occipital, where some laminar necrosis are also present and characterized by intrinsic T1 signal and corresponding susceptibility artifacts. Conclusion from this radiologist was corticolaminar necrosis.
Okay, so this is why I commit.
Yeah.
This is interesting. I'm not exactly sure if I'm in a position to 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 commit to any particular diagnosis, but let me say this. So we've already talked about this. So this is a female of reproductive age, 35 years old female. She's presenting with a chronic symmetrical polyarthritis. So first of all, maybe I should say that whatever we are seeing is a systemic syndrome. Is a systemic syndrome because it involves the joints and it also involves the CNS. And I think imaging has helped us clarify some things here. So both CT and MRI seems to be in agreement. We are seeing a picture, so it's considered to be something as it sounds. Maybe I'm not a neurologist, but in general, I should say the pathology is predominantly vascular. So it's something vascular that has led to the changes that we see. So it's not something structural like a space occupying lesion. It seems to be something vascular. So it's involving the vascular territory in the CNS. And then in the bloodstream, hematologically, we see a mild anemia. We have an elevation in ESR. So what could be this systemic syndrome that is involving the CNS, maybe involving the vascular territory in the CNS because they are reported as lacunar infarcts or necrosis, hemorrhagic transformation of an ischemic stroke. Those were the thoughts. So what is this pathology that is involving the vascular territory in the CNS that is causing a mild anemia, that is causing a symmetrical polyarthritis, an inflammatory, yes, a symmetrical polyarthritis. If I say a polyarthritis, I'm already implying inflammation, and then it's also causing a mild anemia. It's sparing the kidneys, it's sparing the liver, except for the elevation in GGT, which I've not made sense of. And then this high ANA. Yeah, so I think a reflex will be to mention systemic lupus erythematosus, although we do not see, skin manifestations, but I think it's not necessary for skin to be there. So we have an entry criterion, which is a positive ANA. Therefore, since ANA is positive, we can already consider systemic lupus erythematosus. We are seeing that this patient is having a symmetrical polyarthritis, which can be explained by SLE. And then the neuropsychiatric manifestations of SLE that we talk about. So for this, it will be mainly neurological manifestations. We see the memory loss and all these other things. So it sounds like a CNS vasculitis. It sounds like a CNS vasculitis. So, and then the anemia that we see can also be partly explained by SLE, and therefore I think one of the differentials that I'm considering is SLE. So if it's not SLE, what else? Rheumatoid arthritis. So rheumatoid arthritis, because of small joint involvement, I think is important to be considered in this patient because of small joint involvement, which is not very typical of other autoimmune diseases. And then, so it can explain the joint symptoms. What about the CNS manifestations? Many autoimmune diseases can be associated with a systemic vasculitis, including a CNS vasculitis. And therefore, I think rheumatoid arthritis is also worth considering given the positive rheumatoid factor and the pattern of joint presentation. So a negative anti-CCP, we know that anti-CCP is not very sensitive, but is very specific. And of course, rheumatoid factor being positive, it can be positive in any autoimmune disease and even in infections like I mentioned, syphilis and some other infections. So I think I'm struggling to consider a diagnosis of rheumatoid arthritis. So if it's not rheumatoid arthritis and if it's not SLE, what else? A systemic vasculitis. If we talk of a systemic vasculitis that has CNS manifestations and manifestations in joints, but we do not see any skin presentation, I'm struggling to pick any. So I see among autoimmune diseases, SLE seems to be on top of the list here. Now, if it's not an autoimmune disease, what else? Infections, I already mentioned the disseminated gonococcal infection and syphilis. We are told that VDRL is negative. So a disseminated gonococcal infection, we've seen a case here. We do not see any skin presentation again. And given this protracted history, maybe again, I'll keep it low on the list. What about malignancies? We do not see any features that are in keeping with malignancy. So if this is where I commit Joseph, I'll say SLE is on top of my list. Rheumatoid arthritis, I am not very comfortable to throw it away completely, but then a number of pieces of information are betraying it, and that's why I'm struggling to keep it on top of the list. But I think there is a lot that I have not considered in this patient, and given the fact that I've already taken a lot of time, maybe I'll just sit back and learn, admitting that there were serious gaps in a number of areas that if filled could have helped me make progress in this case.
Yeah, I should say I'm so impressed because this is a tough case, as you're saying. I struggled a lot and I had everything in me, but you reasoning and then the discussion is on point and even your calmness, very, very nice. So this patient has gone, as I told you, multiple hospitals. When the husband brought her to me, they came from a neurologist, some hospitals, and then their question was, neurologist told them she seemed to have a stroke. She saw young, she has any risk factor. He wanted to know why. Why is this happening, and if there's anything to be done so that she doesn't get something like this, or it shouldn't progress. And I should say the neurologists didn't have answers, and it's not their fault. As you're seeing, David is mixing neurology and rheumatology. So the neurologist lacked rheum, which shows interest. We're still here. Our market is not going anywhere. This case also shows that. So yeah, David, I think at the end I thought like you, and I didn't knew this thing, and then in my reading I realized neuropsychiatric lupus. It made a lot of sense. It could explain a lot of things, but then I had struggles in that, as I will show later. So SLE is a very big topic. Anything, the teaching point will just be will center on the neuropsychiatric lupus. So as you know, SLE can affect any organ from the eye, skin, hair, any that liver, wherever. So it also can affect the neurological system. So neuropsychiatric SLE can occur before SLE to be being diagnosed. If this patient had presented to someone who is maybe not an OT on that moment with the inflammatory joint pain, I think they could have had a diagnosis. When I was seeing this patient, there was no. It was at the moment there was no flare as far as the joints were concerned. So someone from delivery and then they have inflammatory joint pain. Everyone knows it's SLE. You had to be as SLE. What else? And why should anyone have RIA at age of 30? I mean, at that moment it will be 20 something, and then comes and go. To be hard. RIA is something persistent. They can have flares, but at the baseline there's pain. So that was also SLE. So this came after this NPSLE came after SLE. It was just not diagnosed properly because patient with bone pain in this country, they go to OT. I don't know why. And so if it occurs before, it will be very hard to diagnose. That's what I learned in this case. So the NPSLE is a lot of neuro symptoms depending where it affected. This patient had a stroke, as you can see, and there can be seizures. Cognitive impairment was also present. Patient can have myelitis or depression. This patient didn't sleep. They had those neuropsychiatric manifestations. So of importance, as far as this case is concerned, it is thought that antiphospholipid antibodies, they occur in 30 to 40% of patients with SLE. It doesn't mean these patients have antiphospholipid syndrome. No. If you call it antiphospholipid syndrome, you should call it secondary, not primary, as you all know. Because as I told you, that there is no pregnancy complications. And these are thought to play a major role in stroke in these patients. Like they cause thromboembolism. So the pain that this patient had on the left side of the head, the neck, and the jaw is it should have been considered by those who saw this patient in the first line. I tried to do something, but it was hard, as I'll show you. So the management will depend with the syndrome. Like if you see a stroke, you manage the stroke, preventing recurrence. If you see it as like depression, you manage as depression. But again, you should also treat SLE, the underlying SOD. And I should say also when I thought of this, I told the patient to go back to another hospital where they can meet someone maybe in rheumatology. And nice, I learned later that person started hydroxychloroquine. This patient said, "Okay, we are thinking the same thing. So maybe me, David, this guy, maybe we are right. This patient might be having this NPSLE." So I'll tell you my reflection. I was thinking, what caused the jaw, head, and neck pain? Like, why? And then my reading, some possibilities included if you have a problem is that vessel, there will be irritation of the meninges or cortical pain processing areas, and you can feel pain probably. Or it is also known that post-ischemic pain the MCA post-ischemic pain is sometimes mistaken for dental jaw pain. Patient can go into the ER screaming of jaw pain, only to be found that they are having an MCA stroke, ischemic stroke. But again, another very important thing, and I tried to do this. What if there is a thromboembolism of a big vessel, maybe in the neck or somewhere around there? Then I tried to order MRI, I mean, CT angio in this patient, but the insurance guy said she already done many investigations, so they denied me. Uh, I don't know why, because if someone has a stroke, you do CT to rule out hemorrhage. You can do MRI, maybe if you don't to see some substance, maybe it's not stroke. Why is she young? Let's do an MRI. And then to find the cause, you have to do angio to see what's the vessel look like. Is there a thrombus that is showering the brain with embolites? or is there like a stenosis, something like that? But they said no. So I also needed further labs. Like if I get, I sent this patient for ANA. I thought they would do the whole panel, but turns out they only do ANA itself. So if we get anti-double stranded DNA, it will be elevated. It will be like 100% what we're dealing with, because ANA, as David is saying, some other inflammatory diseases can have raised ANA. And then if we could have complement levels, this is before, and they will be low, the suspicions that we're dealing with NPSLE will be like going 99 point something percent. And then if this patient, if we could test the antiphospholipid antibodies and they were positive, it doesn't mean she has APS, because you need to test that after 1 year again to see if they're still persistent. But it will tell you these are the ones driving the scheme of the brain that we are seeing. Yeah, so this is the case of David. Yeah, very nice discussion. I liked it. What's your reflection?
Thank you, Joseph. I'm exhausted. I'm exhausted. This was a very tough journey for me. I mean, it made me think very hard, and it just humbles me that the diagnostic process is not an easy job, and maybe that's one of the reasons why we come here every Sunday, and that's why we open books almost every day, even though some of us finished our training a number of years ago. So I think there's a lot to be learned from these cases, whether we get the diagnosis right or wrong, because at any point in time, there's almost there's thousands of possibilities to explain the patient's presentation. So as you can see, and maybe we will be modest if we say, or that will be some reservations if we say a few patients who are in this patient's position, that you visit one doctor and then maybe they solve part of your problem, and then someone else deals with another part of the problem. I think there is no shortage of cases like these where people visit health facilities and then they do not find answers to all the questions that they have. And that is where a generalist comes in. That's where a generalist comes in, and it's a tough job to do. So just like Joseph did, to sit down with the patient, take the history, examine, revisit all the investigations that they did, and put together some thoughts, and then you help the patient. So for me personally, I think it's been a lot of learning. I've discussed the headache here many times. I've discussed the joint pain many times, but it took me a very long time to get to a conclusion. And so something else again is just a call to all of us that patients like these need us. It's an exhausting job to do. Sitting with the patient for minutes or even hours, taking history and then revisiting whatever they did in order to help them. But that's what we are called to do. So let's keep doing that. Thank you very much for the case.
Yeah. So I think we are beyond the hour. Is there anything else around here? Yeah. If nothing, I think we should call it a night. What do you think, David?
Yeah, thank you very much, everyone, for joining. So we hope to meet again next weekend. And as always, if you have a case, please reach out. And we hope to see some new discussants again. So if you're willing to do that, please reach out to Joseph or me, and we'll be happy to have the group learn from you. So if there's nothing else, have a good night, everyone, and see you next weekend.
Good night.